All right, so this is chapter 7, and this is pathophysiology, principles of pathophysiology. So it'll kind of give you an overall of how the body works and what each system does. But what really comes into it is how does it work in regards to shock? How does it work in regards to the sick person? And what is it like if you're healthy? Shock is a physiological state. It's how you are. Okay? We have healthy, sick, and shock. Okay? So, pathophysiology is the study how disease processes affect the function of the body. So, understanding it is going to help you recognize any changes in the patient, whether they're going through illness or injury. It all comes back to you being able to recognize if they're in shock or not. So, the shock state is when the body is most vulnerable. When your body is in shock, and it's a vulnerable process, and it's a downward spiral to death if you do not do something about it. So it starts with the cell. Now, the basic components of the cell, this is not like a big anatomy and physiology class where you're going to have to know every part of it. But some things to remember is that the the membrane of the cell is permeable. That means water can pass through it pretty easily. There are also molecules that can pass through it. So, our cell membrane, if you realize, the capillaries are surrounding it. They have to be close together. The capillaries in the cell membrane have to be touching in order for things to diffuse across it. Now, there are times when the cell membrane and the capillary might be more distant from each other. You guys can probably think of reasons why. What do you think? Anybody got any suggestions? When would that capillary be farther away from the cell membrane? Maybe. Not probably so much dehydration. Think the opposite. Fluid. You ever have anybody that has like fluid in their ankles outside of their tissues? It's and that is kind of making a difference in the ability of things to perfuse across those membranes. Bleeding, bruising, stuff like that is going to disrupt that cell membrane and that capillary from the lining. Okay, the other thing to think about with this is that the structures inside, um, knowing that all of these structures work together, it's a little manufacturing company. What are they manufacturing? Energy. Every cell in your body manufactures energy. Now, there's a fancy word for it, and it's called adenosine triphosphate. That is ATP. So you'll see this um, abbreviation of ATP. Think of that as energy. That is what your cell is producing. If it is doing it efficiently, it will create about 36 molecules of ATP. But if it doesn't have the supplies it needs, it cannot create that ATP efficiently, and it'll only produce about 2 or 3 molecules of energy. So, we want to keep this little company functioning optimally by making sure that it gets the supplies it needs to create energy. There are 3 basic needs that this company needs to create energy. What 3 things do you think we need? Yep, oxygen, glucose, and water. Oxygen, glucose, and water. And most vital is oxygen. So if we can make sure that oxygen is getting to every cell in the body, through its transport system in our body, which is the blood, and then it can diffuse across those cell membranes and get in there. Then this company, this little manufacturing plant, can produce ATP efficiently, and there is always a waste product too. Okay, so keep in mind there's a waste product. Waste products cannot build up in our body, and our waste product happens to be carbon dioxide. Okay. All right. So the cell membrane protects and selectively allows water and other substances in and out of the cell. That's called semi-permeable. It lets substances across. Now, there are things that need help getting across that cell membrane, or they need entrance through specific gates. The cell membrane has little gates that it can get in and out of. Well, guess what? We've got our oxygen that can diffuse across, and water that can go across through osmosis back and forth. But the glucose molecule that's also needed, it has to be helped into that cell. It is too large of a molecule to diffuse across. So it has to have a security guard that comes and unlocks the gate that it can go through. What is the security guard that will let glucose into the cell? Say again? It is insulin. Insulin. So, insulin and glucose have to match. You have to have enough insulin in your body to get glucose into the cell. So just keep that one in the back of your mind too, because when we talk about diabetes, that's where that comes into play. All right, so water in the cell. The cell needs the correct balance of water inside and outside the cell. Too little water and the cells dehydrate and die. Too much water, that's going to affect the cellular function. It may be that if it's outside the cell, it's going to drive those membranes apart, or it just might be flooding the cell and drowning it. All right, so water also affects the levels of electrolytes. Our body has certain needs when it comes to salt and electrolytes. So sodium, potassium, magnesium, that sort of thing. That has to be available too, because that impacts the electrical activity of our body. Okay? Well, water follows salt. Salt follows water. I can't remember which one. One of them. But water and salt are like to be together. So you always find them together. Okay? Um, so salt is an electrolyte. So if you are dehydrated, why do you want to drink Gatorade? It's got sodium in it, right? So it's got the sodium and the electrolytes you need. So an important thing to keep in mind too is somebody who's dehydrated might also need some of those electrolytes replaced. So when they dehydrate, the salt goes with it. The electrolytes go with it. All right, so glucose in the cell, I'd already said this, they're the building blocks of energy. Glucose is, and the supply of insulin must match the body's glucose requirement, because glucose cannot get into the cell unless insulin is present. It lets it in through the gate. It binds to it, takes it in. So we always have to have a certain amount of glucose supply in our bloodstream. When we do a glucose check on somebody, if you ever have seen somebody check their glucose, they take a little blood and put it on the machine, tells them what the reading is. That is how much is in the bloodstream. not how much is in the cell. So you could have a lot of it in your bloodstream or not enough of it in your bloodstream. Depends if you've got too much glucose in your bloodstream and it's not getting into the cells, you need insulin to take it into the cells. So that person would need some insulin to help get the glucose into the cell. If you have too little glucose in the bloodstream, you may have too much of it going into the cells, and in that case, they need to eat sugar to bring up the levels in their bloodstream to keep the supply constant, because our body doesn't really store excessive amounts of glucose to pull from. It stores some in the liver in the form of glycogen, but it's a process to get it to pull out of there. So, all right, oxygen in the cell. Now, this is where we get into the metabolism. So, when we talk about metabolism, we're actually kind of talking about what the body really needs to metabolize, and that is oxygen. So, oxygen needs um, to help in the production. That's the basic product it needs to metabolize. So, it's going to go in the cell, and it is going to convert to ATP through the whole manufacturing process that it has. If it is working efficiently, our little manufacturing cell, and if it is creating enough ATP, it is producing a little bit of waste product, carbon dioxide, which kind of goes into our body in the we call it lactic acid in the bloodstream. We eliminate it when we exhale. Comes out as carbon dioxide when we exhale. That is our quickest way to get rid of it. Other ways we get rid of it is we might pass it through our urine. There's different ways that our body can kind of buffer it out. But the biggest way that we're going to get rid of it is by exhaling it. Okay? So if there's not enough oxygen going to the cells for them to metabolize correctly or efficiently, and if you think of somebody doing aerobics and they're healthy, they're pretty healthy and efficient, think about that as the good metabolism. Anaerobic metabolism is inefficient, and it creates not enough energy, really. It only creates two or three molecules of energy. But the big problem is that it is not being done efficiently, and it produces a lot of waste product. So now we have production way down and waste product high. And so our body is going to try to get rid of that waste product. How does our body get rid of waste product? We exhale it. So somebody whose body is moving into anaerobic metabolism, you might see their respiratory rate increase as they try to get rid of that waste product that's building up. See how that kind of plays into it? Okay, so aerobic metabolism, and this is the whole scientific formula for it. If you prefer to look at scientific formulas, they don't do much for me, but what it's basically saying is that glucose gets broken down with oxygen. So oxygen and glucose combine, and they produce a large amount of energy. Up here it says 32 energy. Anywhere from 32 to 36 is what I've seen in the different books that talk about this. And so you see that whole long formula, C6H12O6 plus O2, and then it converts into CO2, which is carbon dioxide, and water, and triangle. I don't remember what those means, but it makes 32 ATP. It probably means ATP, but usually they would put like ATP or whatever. Okay? That's what that whole formula is basically telling you. All right. So anaerobic metabolism is not efficient. You see, it breaks down into glucose, lactic acid, and then you get just 2 ATP out of it. So you have a high amount of lactic acid that is building up in your bloodstream and not really producing much energy from it at all. And that really is what we want to correct. We don't want this to happen to the body. So we have to start looking at signs and symptoms to correct that or to prevent it from happening. So, who knows what shock is? What really is? Yeah, you've ever heard people say that person's going into shock. Okay, so spider scared me. I shocked. Yeah, but it actually is the body's physiological response to not getting enough of its needs. So, first thing you're going to start seeing, which I just explained to you, is that increase in respiration to get rid of the lactic acid. They're not so much trying to get more oxygen in, although oxygen may be part of the problem, and that's why we give oxygen, but more problematic is the fact that it's trying to get rid of waste product. That's what we're trying to do. Our body likes to be normal. Homeostasis is normal. That's what that means. It likes to be in a normal range. We like to be a normal temperature. We like to be a normal pH balance. And our normal pH balance is like 7.4 to 7.6, 7.2 to 7.6, somewhere in there. Just slightly above normal, which 7 is in the middle. If you see that whole range from acid to alkalosis, 7 is normal, but we're a little bit above that. We're like 7.4, I think is considered normal. But so when we start to get slightly acidic, what do you see happening to the body? Number 1, we'll breathe faster because once again, we've got acid in our body we're trying to get rid of. Now we can be on the alkali range too, and that you'll see different things happen there. But I'm really going to harp on more of this acidosis because that's the more common thing to happen. But our goal is to keep all the body substances regulated as normal. And that's where we start checking and we look for normal ranges. What would be a normal breathing rate for an adult? Anybody ever count respirations?
24 per minute or 12 per minute?
12 to 20 is considered normal. Very good. 12 to 20 an adult. In a child, it is 15 to 30 generally. And in an infant, it's 25 to 40 range. With the like neonate can be even up to 40 to 60, the newborn. Okay. But little charts help to keep us with the age ranges. You can look at charts to figure out normal based on the person's size. All right, so when the body is not getting enough oxygen and we're starting to go into an anaerobic metabolism, then our body is going to do battle. It's going to try to protect itself. And what kicks in then is the sympathetic nervous system is our strongest defense. Our sympathetic nervous system is under which part? There's the, you remember we talked about the autonomic nervous system? That's the things that work automatically in our nervous system. So the sympathetic and the parasympathetic are both parts of that autonomic nervous system, and they kind of balance each other out. They work on different things, really, in the body, but they activate different responses. And they activate based on the chemicals that they produce or release. And in the sympathetic nervous system, one of the biggest chemicals that gets released when it gets activated to protect itself is epinephrine. And what is epinephrine? It is an EpiPen. It is adrenaline. It's adrenaline. And yeah, so when we give epinephrine, we're giving adrenaline to somebody. So there's epinephrine, and there's also a chemical called norepinephrine. They both work on a few different things, but they stimulate the body to start producing to to enhance our body capabilities. So it's called the fight or flight response, because this is when you get scared and your heart starts racing, you start breathing faster, and you're prepared to run or fight. And you can feel your adrenaline response. You guys have probably had times where you felt your adrenaline kick in, right? What does it do? It increases the heart rate and the blood pressure. So you could see if the body starts to get a little acidic, or, there's lactic acid building up, and it's like, hey, I'm not getting what I need. I can't produce the energy I need. Now it's going to put a larger demand on the circulatory system. It's going to put a little bit of demand on the respiratory system. Give me what I need, and hopefully I can fix this problem myself. The body likes to fix its own problems if it can, but sometimes it needs a little help. The parasympathetic nervous system, and in shock, we don't talk about it a whole lot because it kind of is more the rest and digest. This is when our body is relaxing. After we eat, it works on digestion. It regulates reproduction too. That's not always a rest, but it's supposedly what chemical is kicking in during that. It reduces the heart rate and the blood pressure. All right. So the parasympathetic system, you can be like, that calms things down. The sympathetic system is going to speed things up and help you prepare for battle. So here's how they balance each other. It's a dynamic balance between the autonomic branches of the autonomic sympathetic or the autonomic nervous system. So the parasympathetic activity usually will dominate unless something happens to kick in the sympathetic activity. So the sympathetic activity is going to speed things up and help you to go to battle. These are the specific areas. There's a lot going on in this slide, but this is really how it happens. The parasympathetic nervous system. So let's just look at the parasympathetic nervous system. When it kicks in, you may see the pupils constrict. Salivation might be increased. It's going to, inhibit the heart. I said that wrong. That is the one that's slowing it down. So I said it wrong earlier. I just realized that. It's going to constrict the bronchi. It's going to stimulate digestive activity, stimulate the gallbladder to release bile to break down whatever you eat in the stomach. The bladder is going to contract. The rectum relaxes. This is normal. But let's look at the sympathetic response. This is our fight and flight, and this is what's going to kick in. We've got our pupils are going to dilate. We're going to it's going to kind of start keeping water to itself to keep the blood pressure up. So mouth might be dry, thirsty even. Bronchi is going to relax. Um, heart rate's going to go up. We're not going to be digesting stuff. In fact, you may even empty your stomach. Some people vomit when they get excited. Um, it's going to stimulate glucose release by the liver. Remember I told you there's little bits of stores in the liver? It's a more complicated process than having it just ready on the shelf in the bloodstream. But it'll start pulling things from where they need it to try to protect itself, to get things done. And this is where the epinephrine and the norepinephrine that are stored in the kidney are going to release. Because that's the chemical that makes things speed up. And of course, the rectum will contract. So, what we might see is pale, cool, clammy skin as the blood vessels constrict to increase blood pressure. Um, you're going to see the heart rate increase. You're going to see breathing faster to try to protect itself. But all of these things might happen. Now, there are times when these things might specifically not happen in a shock situation. Let's say you go and you see somebody that's pale, cool, and clammy. You believe that they are in shock. And for all intents and purposes, they're breathing faster, pale, cool, clammy, all of these signs and symptoms that you see of shock, but yet you check their pulse, and their pulse is 80. Now, a normal pulse is between 60 and 100. But I just told you if the sympathetic nervous system kicks in, the heart should accelerate. Wouldn't you expect somebody who is got an adrenaline response going on, their heart rate to be fast? So now why wouldn't it be? What is inhibiting the heart from speeding up? A lot of people take medications to control their heart rate. So an older person that's taking a medication that is controlling the heart rate, their adrenaline might kick in everywhere else, but not on their heart rate. Okay, so as we start looking at the different signs and symptoms of shock, we're going to look at them. We're going to say, this is a normal response of what happens when this person is in shock, but I see an abnormality. Why do I see it? Well, I'll look at the medications and I will see, do they take a medication that controls the heart rate? All right, so let's talk about how each system reacts then. What each system is going to do. Their pathophysiology as it relates. So our cardiopulmonary system are the two main systems that are going to respond in shock. So these are our main systems. These are the ones that are always working together. They keep us normal. Our respiratory and cardiovascular systems work together. What they're doing is bringing oxygen into the body, and then the bloodstream is picking up the oxygen in the lungs and distributing it to every cell in the body. And it's picking up the waste product that that cell has created, and it's taking it back to the lungs so the lungs can get rid of it. So if there is a breakdown in the cardiopulmonary system, then you would see, obviously, signs and symptoms of shock, right? So remember, as we go through this that the blood comes in on the right side of the heart, the right pump, to the atrium, down to the right ventricle. Then it goes out to the lungs, gets rid of carbon dioxide, picks up oxygen, comes back to the left side of the heart, to the atrium, down to the left ventricle, and then it goes out to the aorta, to the body, to distribute the oxygen molecule and pick up carbon dioxide and come back to the right side of the heart. Okay? Remember, that's how that goes. All right, so this is the respiratory system. This is the airway. This is the lower because it starts at the trachea. That larynx is there at the top of the trachea. What is the larynx again? Voice box. All right, and then it goes down through the trachea, and then it divides into right and left bronchus. And that little part at the bottom where it bifurcates, where it divides. Anybody remember what I told you it was called? C. Carina. You're right. It is the carina. Carina. And then it goes down to the smaller bronchuses and then down into the very lower airways, which are the bronchioles. And then the alveoli is where the cells that hold the oxygen that the capillaries surround, they have to be close together, the alveoli and the cell membrane, to pick up the oxygen. Once again, if they were becoming farther apart, what might be going on in the lung? Fluid. Okay, you ever see anybody that has congestive heart failure and they have a lot of fluid in their lungs and a hard time breathing? They see fluid in their ankles too. Well, that fluid is seeping out of the capillaries and it's causing the cell membranes to be farther away, and then they've got fluid in their lungs. And we call that pulmonary edema because it's swelling. All right, so here's our alveoli. Our alveoli surrounded by the capillaries so that oxygen exchange can take place. And they have to be close together and they have to be shaped nice, have a nice surface area. There are certain diseases where those alveoli are damaged and break down, and then the surface area is not really efficiently working, or there's not enough of it. Specifically, if they have like COPD, where they've damaged their lungs from something, smoking, or even bad air over the years. The other thing that you want to look at is those bronchioles going down there. On the left, you see the bronchiole going down to the alveoli. Do you see how there's muscle bands around that? Those muscle bands will squeeze and constrict those bronchioles and make them smaller. So when they constrict, it's harder for air to get down. That is what's going on in asthma. That's what's happening to an asthmatic. Those bands are constricting as a reaction to exercise, stress, an allergen, and it's going to constrict those bands, and then air is not going to be able to go through there because they're so tight. We want to open up those. Okay, let's think back to the sympathetic response. When the sympathetic response kicks in, what happens to bronchioles? Do they constrict or dilate? They dilate. So what can we give to dilate those vessels, or those, not vessels, the bronchioles? Albuterol is a bronchodilator, yes. But what else dilates them in the sympathetic response? When the sympathetic response happens, adrenaline kicks in. What did I say adrenaline was? Epinephrine. Okay? But You are right. Albuterol is the first line for an asthmatic. But I'm trying to get you to think about, I want to open up the bronchioles. Maybe albuterol, which is a bronchodilator you can inhale, but if that doesn't work, I have something else I can give that'll dilate it too, right? Epinephrine is adrenaline. It's going to dilate the bronchioles. That is really what we're doing when we're thinking pathophysiology and how can I fix people. All right. So let's talk about the lungs and the lower airway. First of all, we want to make sure the air is getting down to the lower lungs where the alveoli is. They have to pass through those bronchioles, so we do have to make sure the bronchioles are open. We also have to make sure there's not like a lot of mucus plugs in there, and somebody that has pneumonia might have a lot of mucus or swelling. There might be fluid in there. But how do we know if we're getting it there? Well, there is a formula here, and the amount of air that we breathe in with one breath is called tidal volume. That's how much air we take to fill our lungs. So, nice deep breath. Get it all the way down to the lower lungs. You are filling your alveoli. Now, you can take big tidal volumes or you can take little tidal volumes, but the normal person takes in about 500 milliliters of air. This one says 600, but that's how much goes in and out in a minute. But our volume is about 500 milliliters when you breathe in for the average adult male. Okay, so we don't have anything that measures that unless we're a respiratory tech and we're going out and measuring how much air goes in and out. If you've ever done one of those like pulmonary tests and pulmonary function, they're measuring all that stuff. But in EMS, we really don't know what the exact volume is they're breathing. So what do we have to rely on? Well, pulse will play into it, especially in kids. So I mean, yeah, kind of, but something even better than that. How big a breath they take, right? So as we get older, elderly people will tend to breathe more shallow and only use maybe the top part of their lungs, which may cause problems, which is why they're at risk for pneumonia because they're not constantly filling the lower airways. Um, we know these kind of things, but we look and see, are they breathing shallow or are they breathing deep? All going to tell us if we've got that oxygen getting to where it needs to be in the alveoli. So really, tidal volume for us, we want to make sure that they're getting a good breath, an adequate breath, enough to keep them oxygenated and to eliminate carbon dioxide. Now, minute volume is the amount of air that's moved out in and out in 1 minute. That's how many times we breathe times how deep we breathe. So if we get 500 milliliters of air with one breath, and we multiply that by 12 breaths a minute, then it's about 6,000 milliliters of minute volume. And that is exactly what we do to determine if they're breathing correctly or adequately. Okay? So as we go through this class, one of the things you're going to do when you assess your patients is you're going to say, is this person breathing adequately? What two things are you going to look at to determine if they're breathing adequately? how deep they're breathing, so tidal volume, and how many times a minute they're breathing. And that's going to tell us if it's adequate. And then we're going to look and see, are they showing signs and symptoms of shock? Is it enough to help them, or do I need to help them? Okay, so if we don't have an adequate rate or an adequate depth, if one of those is not adequate, then we are going to help them breathe. So they could be breathing really rapid of about 36 times a minute, and 12 to 20 is normal for an adult. And you come across this guy who's breathing 36 times a minute. First of all, is his rate adequate? It's too fast. And it's so fast that he probably can't get an adequate tidal volume. So he'll be breathing rapid and shallow. On a test question, they're going to ask you, what is, that you've got a guy that's breathing 36 times a minute and it's very shallow. Is it adequate breathing? No. It's going to say, what do you want to do for it? What are you going to do? Ventilate him with a bag valve mask to get bigger breaths in and to slow the breathing. Okay? So this is what we're looking for when we're talking about that tidal volume. Okay, respiratory dysfunction. So you can also have a disruption of respiratory control. Our brain controls our breathing. Our brain, now it does work like our respiratory system works like the syringe, negative pressure. We've got active process and passive process. So when we breathe in, our muscles contract. What tells our muscles to contract? The brain. Okay? So the brain, it's up in what we call the medulla oblongata, which is kind of at the base of the brain. It's in the it's in the pons. But it is our vital function center. It's at the base of the brain. Okay? And it controls all those vital functions. And it tells us when to breathe. How that happens is our body has sensors that are measuring carbon dioxide in the bloodstream. When the carbon dioxide is too high, it wants to get rid of it. These are called chemoreceptors, chemical receptors. And the chemical it's measuring is carbon dioxide. Wants to get rid of carbon dioxide. So when there is a high level of carbon dioxide, the brain is going to take that reading and say, woo, got to get rid of that. And it's going to send a signal to the diaphragm and to the muscles that are between the ribs. And it's going to tell them to contract. And then we're going to breathe in. You could have a disruption of that. How do those signals get to the muscles? Through what system? Nervous system is going to send those signals down there and tell the muscles to contract. But if I break my neck and those signals are disrupted, will I be able to take a deep breath? No, because those muscles won't respond, because the transmitters never get there to stimulate them to contract. So that is a disruption of respiratory control. It can happen with, like a spinal injury. It can also happen in a collapsed lung. The muscles won't be able to or the muscles might respond, but the lung is collapsed, and that might be a disruption of respiratory control. Traumatic brain injuries is a big thing, though. Drugs, toxins, infection can all affect that rate and volume. So somebody with a traumatic brain injury, you might actually see, as their brain is swelling, you might see changes in how they breathe. Really fast, really slow, really irregular. They may stop breathing for a while and then breathe once in a while. So those kind of things can happen if you've got a traumatic brain injury because our brain controls our breathing. Um, so and this one is actually disruption of pressure, which I told you a collapsed lung. A collapsed lung technical term is pneumothorax. And that's going to be a hole in the chest wall. And so the chest wall isn't going to be able to expand. Yeah.
Oh, this is a little off topic, but along lines of breathing. What is it called? Like, what does it mean when the baby stops breathing, like when it's cracked, like the breath swells? Like, what causes that?
Some kids get so excited that they do quit breathing. I don't know exactly what it's called. Uh, but they can. Like kids will hold their breath until they stop breathing. But once again, when they pass out, it's going to come back. The control center is going to take over. It is difficult for you to hold your breath until you pass out and not have the brain take over because that's the brain saying, I don't have enough oxygen, so you pass out and now it's going to take over again. I mean, but yeah, I do know what you're talking about. I have a granddaughter that does that, but they'll pass out and it starts again. So even when it is an involuntary action, you can't like stop it completely because at some point you'll pass out and the brain will take over your breathing. Disruption of lung tissue. This is another part of respiratory dysfunction. So if there's something wrong with the respiratory system, it's not going to function adequately. And we have to fix those problems if we have them, if we see them. So, disruption of lung tissue might be trauma, like bruising in the lung itself, where there's blood in between the capillary membrane and the alveoli. Oxygen can't cross over and carbon dioxide can't get out. And that's going to result in what we call a low level of oxygen, which is called hypoxia. Hypo is low, oxygen, and carbon dioxide, which is hypercapnia. All right, so the respiratory system will try to compensate for that defects. Remember, I told you the body likes to protect itself. There are ways it will compensate for things. So if there is an exchange problem and there's not enough oxygen exchange going on, then the chemoreceptors might detect those changes and the brain will stimulate the respiratory system to increase or it might stimulate it to increase tidal volume, either one or both. So people will breathe faster. So our natural response, remember, our respiratory rate goes up in shock. That's our natural response of our body compensating. The blood also. Now with our blood, we have to have four things. We have our plasma, we have our red blood cells, our white blood cells, and our platelets. So plasma is the fluid that circulates around. If you don't have enough fluid in there, it's not going to be able to circulate as easy. It might become thick and stagnant. Red blood cells are really what we have to have, and we have to have them in adequate supply because the red blood cells carry oxygen molecules. They attach to the red blood cell, and the red blood cell circulates them around until they get to where they need to be, and then they shoot over into the cell when there's enough pressure. It's areas of high and low. So if the cell has a low oxygen concentration, so the oxygen passes over there to try to equalize it. Whereas the carbon dioxide comes back because the capillaries have low carbon dioxide, and so it passes back over. So it's constantly that shift back and forth, trying to equalize out. That's how they move. White blood cells, they fight infection, and the platelets form clots. The platelets, when they are activated, when the body sees that there is a cut in a vessel, the platelets will be activated, and they form like these little sticky legs. I don't know what to call them, little sticky arms, to where they stick together and they form a scab. They form clots, and that heals us over. There are things that can inhibit that, though. We take medications that maybe try to thin our blood. They're not really thinning our blood, they're just preventing the platelets from activating, and they're keeping them lubed up and not sticky. So, the blood needs to be flowing through all of the vessels, and there has to be a little bit of pressure in there. They call it oncotic pressure, um, in order for the molecules to pass back and forth. So the proteins in the plasma will attract water away from around the cells and pull it into the bloodstream. Hydrostatic pressure will push it back out of the blood vessels towards cells. So this pressure kind of keeps the water flowing back and forth to maintain hydration. If we have problems with any of these proteins, there can be an imbalance in the water and the pressures. The blood. So we could have problems with the blood itself. Um, you could have a disease where maybe oxygen and carbon dioxide can't really be moved around enough. So, like, well, let's first just talk about not enough blood. So, if you're bleeding and you don't have any red blood cells, you're not going to circulate oxygen. And there's nothing that we have found to replace red blood cells yet. I mean, they've tried different things, and I'm sure they're still trying to manufacture fake blood that we can replace blood with people, but to date we don't really have anything that is good at replacing it. We give fluids just to kind of help circulate it around, but the only thing that's going to carry oxygen is red blood cells. We don't want to lose a lot of red blood cells very quickly, because then they won't be able to transport that oxygen. Dehydration is the fluid to keep it circulating around. Anemia is specifically from not enough red blood cells. And liver failure, of course, that's where our red blood cells are sent to kind of um, process in the end. I think it I don't know, it regenerates them maybe. I don't know. But it does something. The liver does do something with your red blood cells too. All right, so our blood vessels have to be working effectively. I, did I say blood vessels, right? Okay. I got thinking about red blood cells and thought I said the wrong thing. So, our blood vessels have to work effectively. Our blood vessels can increase in size and can also constrict. So, if our blood pressure is low, what do you think the body will do to compensate, to try to increase it? They'll constrict to try to make them smaller to increase that pressure so it circulates through. Our blood vessels dilate to drop blood pressure to try to make it lower. But if our blood vessels are dilating and we don't want them to, then we could have a drop in blood pressure that we don't want. Okay, so let's talk about somebody that has an allergic reaction. Their blood vessels dilate. And what is it that our sympathetic response is? Adrenaline. And what does adrenaline do for blood vessels? Constricts them. So you have somebody that's having a severe allergic reaction. Their blood pressure has dropped because their vessels dilated. What can we do to fix that? Give them epinephrine because adrenaline, once again, will constrict those vessels. And that is why we give epinephrine for an allergic reaction, a severe allergic reaction. We have to make sure that their blood pressure is actually dropped, though, because do we want to give epinephrine to somebody whose blood pressure is high? No, we don't want to increase it. Because epi is adrenaline. Epi and adrenaline are the same thing. So the one thing I want to point out in this slide too, though, is in the shock response. This is another thing that happens. So in the shock response, the circulation, as the body tries to protect itself, the vessels will constrict naturally when the adrenaline relieves. But then the capillaries have little sphincters. There's a pre-sphincter and a post-sphincter. So there's like little gates, and they're not really showing this on here, but there's little gates before and after the capillaries. And those gates can close. And when those gates close in the shock response, that blood that's in there in the capillaries continues to exchange oxygen and carbon dioxide. And what do you think will build up in that blood that's in those capillaries? Carbon dioxide. So our waste product has built up in there. Now when we finally when shock gets really progressed, so remember, in shock, when the body compensates, the vessels constrict and these sphincters will close. And then when shock progresses, eventually these vessels are going to be like, I'm tired, I can't constrict anymore, and they're going to relax and they're going to dilate. And what do you think happens to all that blood that's trapped in those capillaries? Now it flushes throughout the system, and they call that like washout. And that is where lactic acid has built up quite a bit. So not only have we suddenly increased the lactic acid going on in the body, but this is happening late in shock as you see them beginning to die, decompensate, we call it, as they move through. So that's another thing to think about is happening in your shock patient is you're battling lactic acid. So our circulatory system, our vessels take oxygenated blood from the lungs via the heart to the capillary. Oxygen exchange takes place in two places. Okay? I think there was a little bit of a test question on this, or a quiz question that we did. So gas exchange takes place between the cells in the body and the capillaries. And gas exchange takes place between the capillaries and the alveoli. Sometimes you will see in some books, they will tell you exactly what that is called. So I'm just going to mention this to you. I don't see too many test questions on it, but I have seen once in a while. They call it external respiration or internal respiration. Now remember, that exchange at that cellular level is called respiration. That's really what respiration is. If you want to get technical, it's happening in the cells. and in the capillaries. If it is external respiration, it's happening between the capillaries and the alveoli. If it's internal respiration, it's happening between the cells of the body and the capillaries. How do you keep those separate in your mind? External air is coming into the lungs. So external air is exchanging between the alveoli and the capillaries. Once it circulates to the cells, it is now internal. It is deeply internal. And that's how I try to remember it. Because, yeah, they're both happening inside the body, but one is exchanging with external environment. Okay? So the blood vessels need adequate pressure to make the cycle work. The pressure is controlled by the diameter of the blood vessels. And stretch receptors monitor pressure. They're called baroreceptors, like barometer. It measures pressure. So a baroreceptor is a stretch receptor that measures the pressure in the arteries, and it can increase or decrease depending on the body's needs. So sometimes we get that constriction, sometimes we get that dilation. And here's where we get our loss of tone. So if the vessels lose their ability to constrict or dilate, they're just going to relax and dilate, and that pressure drops. So look at how much drop in volume you would get of blood. You may have the normal amount of blood, but when your vessels dilate, your blood pressure will drop simply because you now have more pipe to fill. Some things that can cause that are trauma, infection can cause it, allergic reaction can cause it. That all causes the vessels to dilate. And you can also have that loss of permeability of the blood vessels. So that permeability is the ability of the water and oxygen to cross. So capillaries can actually leak the fluid out of their cells or out of their walls. And sepsis can cause that. Infection can cause that seepage. You can also have it in high altitude, and then in some diseases that happens, like congestive heart failure, sometimes that happens too. Hypertension is a high blood pressure, high tension, hypertension. Systemic vascular resistance is the pressure inside the vessels, and there can be an abnormal constriction of vessels, and that could lead to an unhealthy high pressure. And our vessels can also have become stiff as we get older, and they get like more clogged and stuff. That can lead to hypertension. You can also have loss of regulation of the vessels when maybe signals are blocked. Now, what sends signals to the vessels to constrict or to relax? It's the brain once again, and it's also that sympathetic response. So the sympathetic response is adrenaline being released. If we don't get that adrenaline being released, we may not get that constriction. So sometimes the sympathetic response can be blocked. I can't think of a reason why right now, but I will, and I'll let you know. The heart also needs to pump an adequate amount. Now, the amount of blood that the heart will pump in one stroke, in one beat, is called stroke volume. It's about 70 milliliters with every contraction. Just like with the lungs, where you have to take rate and tidal volume to get a minute volume, the heart we calculate too. So there's a calculation. It's like stroke volume times rate, equals the cardiac output. I think it might come up here, but the other thing that bases is on is how do we get a good stroke volume? Well, first of all, you have to have good preload. You have to be able to fill it with an adequate amount. So that means the blood has to come back to the right side of the heart. An adequate amount has to come back to the right side in order to fill the heart. And then the heart has to be able to squeeze hard enough, and that's its contractility. And then there has to be a little bit of pressure that it pumps against, which is called the afterload. That's how much squeezing the vessels are doing. That's the afterload. So if they have high blood pressure, the heart has to push harder, contract harder to get past the afterload. But the preload is pretty important. The more we can load our heart, it's like a rubber band. If we can if we can stretch that heart muscle really far with good filling, it's going to push farther and harder, and you're going to have a good um, amount of cardiac output with that. So cardiac output is our stroke volume times the beats per minute. And what is the beats per minute for an average adult? What's the average heart rate? 60 to 100 beats a minute is considered normal. So if we have a good stroke volume and we have good rate, then we're going to have a good cardiac output. How do we know if it's good? How are we going to check cardiac output? What? Pulse. Yeah, we're going to check the pulse. So here's the things we're going to watch for on test questions. Rate and strong or weak. We rate our pulses. We can't really give you a volume. We don't know how much is coming out we're not measuring the amount of blood that the heart's pumping, but they are in the hospital. But we can kind of tell if we've got a strong pulse, we've probably got a good pressure going on. And if we got a good rate, probably adequate. But if it's weak, slow, absent, um, or even way fast, we might not have a good cardiac output. So we're checking those normal limits. So once again, when we assess our patients, we look at their breathing. Is it adequate? What do we look at? Rate and volume. We want to look at the pulse. Is it adequate? What do we feel in the pulse? Is it strong, weak, absent, and what is the rate? That's going to tell us if we've got good cardiac output. Pediatric patients, just a note here. Pediatric patients rely on their heart rate to compensate when they're not getting good circulation or good perfusion because they lack contractile muscles developed. They're not quite developed yet, and they can't regulate the force of that contraction like adults can. And sometimes we can give medications that will regulate the force for adults, but they will compensate with fast heart rate. So a fast heart rate in a kid is them compensating. And they can compensate for long periods of time because they probably have a really young, healthy heart. But when they spiral down, they do it quickly. Okay, so with kids, we really want to pay attention to that rate. So we can have problems with the heart, mechanical problems from a physical trauma to the heart, or we can have a squeezing problem with pressure being put on the heart, or we could have the cells of the heart die, such as in a heart attack. We could also have electrical problems where the heart's electrical system is not working well, and we could have unorganized rhythms and rate problems. So, shock. So the term shock I asked you guys this before. What is shock? It is a physiological state, but our technical term for it is hypoperfusion. Perfusion is when the body is getting adequate nutrients, oxygen, and the removal of waste products. Hypoperfusion is low perfusion. The street term for it is shock. It is a breakdown in the system, and it can result in death of your patient. So it is important for you to recognize the signs and symptoms of shock. All right, so basically, when we talk about shock, there are four categories of shock. Now, shock is basically a cardiorespiratory problem. It's actually a perfusion problem, hypoperfusion, so it's a perfusion problem. And what system controls our perfusion? The largest part, in the largest part, it's the circulatory system. Controls our perfusion by circulating the blood around. And there are three components to the circulatory system. We've got the heart, we've got the vessels, and we've got the volume or product, which is blood. So three things we need to perfuse. Yeah, we need something to make everything go round and that sort of thing, but we've got our electrical and all those add-in components. But let's get right down to those three things. So we've got a pump problem, a vessel problem, or a volume problem in any given type of shock. It's for us to know which problem we have to deal with. Do we have to try to constrict the vessels? Do we have to add more fluid or volume? Or do we have to do something to fix the heart? And that's how we get four categories of shock. And these are the basic categories, and every type of shock will fit into one of these categories. So we have hypovolemic shock, low volume. What is the problem? It's a blood problem. It's a volume. It's going to be either fluid in the circulatory system, not enough of, or not enough red blood cells. So dehydration will fit into a hypovolemic shock. Somebody that's dehydrated will have a hypovolemic shock. Somebody that has blood loss, a hemorrhagic shock from hemorrhage, has a hypovolemic shock, low volume. Distributive shock. It is a blood vessel problem. The blood vessels have dilated in the most part, and blood pressure has dropped. So this happens because of low blood vessel tone. Now, throughout this lecture so far, I've given you three possible causes of losing tone in your blood vessel. One was in an anaphylactic shock, right? One was in a nervous system problem where the blood vessels lost tone from a broken neck and the blood vessel dilated. And there was another one, which is sepsis. And I didn't point that out like specifically, but sepsis is another problem. I did say that fluid leaks out in sepsis, so there is a little bit of loss of fluid, but it causes another thing that happens. It's an immune response. An allergic reaction is an immune response, causes dilation of the vessels. So sepsis, anaphylaxis, and a neurogenic shock are all types of distributive shock, and they're all caused by a low blood vessel tone. The blood vessels have dilated. So theoretically, we can fix a lot of distributive shocks by giving something to constrict the vessels and bring that pressure back up. Okay? Cardiogenic shock is a heart pump problem. The heart is not pumping effectively. This can happen in a heart attack. This can happen in congestive heart failure, where somebody has had a heart attack and now their heart can't pump effectively because part of the cells in it have died. And so it's not able to pump like it should. And the last thing is an obstructive shock. And so you say, okay, so we've got a fluid volume problem, we have a vessel tone problem, and we have a heart pump problem. And I told you there was one of those three things wrong in every type of shock. An obstructive shock says blood cannot flow. So blood cannot flow because something is causing the heart not to be able to pump it adequately. So in some books, you will see obstructive shock listed as cardiogenic. But it is a separate category because it's specific to something causing the heart not to be able to pump. Think about if you have a collapsed lung. If your lung collapses, you get air in the chest cavity, and that muscle part of your lung is pushing, pushing, pushing. What is it pushing against? The heart. And as the heart gets put under pressure and squeezed by all the pressure in the chest cavity, it's not going to be able to pump. It's not going to be able to circulate that blood like it should. It's an obstruction. And so when that blood can't move forward, it backs up. And you know what you see when the blood backs up? Jugular vein distension. You'll see somebody's jugular veins just like pop out. They're like really big. That's because the heart's not moving the blood forward and it's backing up. And you will see that when there's high pressures on that. So, a pneumothorax, a collapsed lung, is one cause of an obstructive shock. There are actually three things that will cause obstructive shock. One is a tension pneumothorax. The other one is a pulmonary embolism. Has anybody heard of that before? It's a blood clot that generally it comes from people who has like leg surgery, or they get blood clots in their legs and they come to the right side of the heart, and they go out through the pulmonary artery and they get stuck there. And then you have this big clot in your pulmonary artery and it blocks blood flow. The blood can't go forward. The heart's not able to push it through. It's an obstruction, truly, an obstruction. Blood flow backs up. What do you see? JVD. And it's obstructive shock. So a pulmonary embolism is the second thing that causes an obstruction. And the third thing that is an obstruction to the heart is something called pericardial tamponade or cardiac tamponade. It is the sac around the heart is called the pericardial sac. Somebody maybe gets stabbed close to the heart. Blood will leak into that sac, and the heart is in there trying to fill up and push blood forward, but blood fills that sac and squeezes the heart to where it can't push the blood out. It's called pericardial tamponade. Not a real common thing, but it can be common in like stab wounds or or any type of penetrating injury to the center of the chest. You'll get bleeding in that heart sac. The heart can't pump effectively. And then you see what? Blood backing up and jugular vein distension. So, while this isn't like 100%, I like to tell people recognition of an obstructive shock is probably going to be some JVD. It's an obstruction of the heart being able to pump things forward. Okay, so 4 categories of shock. We've got hypovolemic, distributive, cardiogenic, and obstructive. We can put all types of shock into one of those 4 categories. So shock, once again, I told you, is inadequate tissue perfusion. So it's generally a failure of the circulatory system. One of those 3 things are going to be wrong. If hypoperfusion persists, then the cells and the organs will die. 4 causes: volume problems, pump problems, blood vessel tone problems, or an obstruction of blood flow. Hypovolemic shock, blood is lost. Could be plasma, which would be a dehydration, more relative type hypovolemia. But there's not enough blood volume in the vessels, so the blood pressure is going to drop, and it's going to be called hypovolemic shock. Pump problem caused by failure of the pump to pump blood. It's usually a mechanical problem of the heart. Blood can't really be moved because of a drop in blood pressure, um, but it's called cardiogenic shock. It's a pump problem. Or a blood vessel tone problem, and all the blood vessels dilate at the same time, and the pipes, you've kind of increased the size of all the pipes in your body, and the blood pressure can't fill them, or the blood can't fill them, so the blood pressure drops. And this is a distributive shock. One way to think of it, see, all these things are anaphylaxis, neurogenic, and sepsis. All of those things are distributed throughout the whole body. Our nerves are throughout the whole body. Anaphylaxis is happening throughout the whole body. Sepsis is happening throughout the whole body. So it might help you to remember distributive shock as something that's going on through the whole body. An obstruction of blood flow is an obstructive shock, and the 3 conditions that cause obstructive shock is pulmonary embolism, cardiac tamponade, and a tension pneumothorax. These will kill, and they will kill quickly. Most common problems with pulmonary embolisms are people that have blood clots that went to, you'll hear people say it goes to their lungs, blood clot go to the lungs. It can go to the lungs, but a lot of times the real deadly ones happen in the pulmonary artery. Cardiac tamponade is the sac around the heart fills with blood, and tension pneumothorax is the lung collapsing. You can relieve a lot of these. I mean, these, if you know about pulmonary embolisms, if you know you're susceptible to blood clots, they'll give you like blood thinners to help prevent it, or they may put something called a green field filter just before the right side of your heart to filter clots. Cardiac tamponade, those most commonly happen from penetrating wounds like stabs somewhere near the heart. And tension pneumothoraxes, those you can try to relieve the air that's trapped inside by, you'll see people get chest tubes and stuff to get that air out. So our fight or flight response, the baroreceptors are those stretch receptors. They're actually in the aortic arch. They're in the aorta, and they're kind of sensing how much stretch is in the vessels. But they will stimulate the sympathetic nervous system. The sympathetic nervous system releases epinephrine and norepinephrine, and this is where you see blood vessels will constrict. Skin will become cool and pale because those vessels constricting are also moving farther away from the surface of the skin. Skin becomes sweaty. Kidneys will start to keep the urine in case they have to put fluid back into the system. Remember, I talked about that yesterday. Nausea and vomiting. In fact, some people will empty their stomach. And the heart rate and contractility will increase to help compensate. So these things here is our sympathetic nervous system kicking in. These are an indication that the person is going into shock. So we look for this. These are things we look at. And that is also when the body starts to compensate. So I just told you the 4 different kinds of shock. Now I'm going to tell you there are stages to shock. So not only do you want to know what type of shock it is, what's causing it, so that you can work to fix it, you also want to know what stage of shock they're in. This is called the compensatory stage. When we see their heart rate increase, we see their breathing increase, we see their vessels constrict, that keeps the blood pressure up for a while. So we're going to see that compensation is meant to keep that blood flow going and adequate. It is a cardiopulmonary response. And compensation actions, collectively we call it compensated shock. That is the first stage of shock. Compensatory stage of shock. It's the body protecting itself. The next stage of shock, oh, let me go over the pediatric thing again, just so you remember. The pediatric note here, remember, infants and children, their compensation mechanisms don't kick in very well until about half of their blood volume is depleted. And so don't wait for a drop in blood pressure to identify shock in kids. Start treating them when you start seeing that increase in heart rate, because remember, that's how they compensate the most. In kids, fast heart rate is a key indicator of shock. The next stage of shock is called decompensation. This is where shock doesn't have enough fuel. It doesn't have enough to keep up anymore. And so the systems start to fail. This is when the muscles are like, oh, I can't keep up. We're tired and we can't do it. And the key indicator of a decompensated shock is a drop in blood pressure and a change in mental status. Their heart rate may slow and the respiratory rate may slow, but your key indicators that you're looking for is a drop in blood pressure and a change in their mental status. So they'll become more confused or even unresponsive. So here's the thing. You can identify what stage of shock they're in the very first 10 seconds that you arrive at their side. And this is something you should do when you arrive and then periodically throughout. Check a pulse and check their mental status. 2 things you should always know about your patient. The state of their radial pulse. If you check a radial pulse and it is strong and regular, their blood pressure is adequate. If it is weak, It is beginning to drop. Test questions. If they say the pulse is strong, your circulation is adequate. Your radial pulse, if it's strong, is adequate. If they say it's weak, they're keying you in to it's getting close to drop. And what do we know if it drops? They're going to enter decompensated stage of shock. And we don't want people in decompensated stage of shock. Okay? Just a key trick of what you're looking for. Irreversible shock is just that. It's irreversible. It's a prolonged vasoconstriction. The organ system is damaged because they've been without oxygen for too long, and the cells in that tissue will begin to die. You can resuscitate people from an irreversible shock, but they will die maybe just 2 or 3 days later because their organs have not been able to overcome the lack of oxygen that they've had. This is when they die 2 or 3 days later from their kidneys shutting down or their liver shutting down. Those are the organs that are like, yeah, we gave it a good one, but we can't come back from it. All right? So we irreversible shock is just that. It is irreversible. They may not die right then, but eventually the organs won't come back from it. So it's up to you to recognize compensation. You want to know when your patient is in shock and whether it's compensated or decompensated. So compensated shock, you might see a slight mental status change, might be just real slight, maybe a little confused about the date or something. Their heart rate's going to go up, remember, because the sympathetic nervous system is kicking in. Their respiratory rate's going to go up. You're going to see maybe a delayed capillary fill time. So capillary fill, you squeeze the nail bed till it turns white. You let up. It should be pink again within 2 seconds. Count. 1, 2. It's pink. I've got good circulation. This is reliable on kids, not adults, because anything can affect whether or not our finger fills up with blood again. If my fingers are cold, my fingers might be white before you even press down on them, right? So take that into an account. It's not reliable on adults, but it is very reliable on infants and kids. And pale, cool, clammy skin and sweating. Remember, this is the body's response. This is the body trying to protect itself. So we look for those for compensation. And then we remember the sympathetic nervous system and what it does. Um, we're going to have dilated pupils. We're going to have, and remember the things that can affect these little things. Overall, this is what you would see in a patient. But let's say I've got a patient that had a narcotic overdose. Would I see dilated pupils? No, their pupils are constricted if they've overdosed on a narcotic. So I may see all the other stuff. So when we get to the medical part and the trauma part, we'll throw in the little things that might change some of these. But for the most part, when we're talking shock, we're going to see the sympathetic nervous system respond. If we don't see it, we're going to be like, why? Why isn't it responding? In a neurogenic shock, you won't see the pale, cool, clammy skin, and you won't see the you might see the heart rate normal because the stimulus to change it isn't getting through because of the broken neck. There's little things there that you might see as differences, but I want you to get this down and then we'll talk about the various things that might clue you into as to what type of shock it is. Decompensated shock occurs when the compensatory measure fails, And what do we know? It is a decreased blood pressure and altered mental status are the key things that tell us they're in decompensated shock. Irreversible shock, the death follows. Fluid balance, the body is 60% water. This is just kind of more general physiological stuff to be aware of. Just a few more slides will kind of key in the rest of this physiology stuff. But the body is 60% water. We have our intracellulars, which is the fluid in the cells. About 70% of it is in the cells. Intravascular is what's actually in our blood vessels floating around. There's only about 5% there. And we actually have about 25% that are in the tissues themselves, not in the cells, not in the vessels, but kind of in our other tissues to keep them moist. So the brain and kidneys regulate that. Brain and kidneys regulate thirst and also the elimination of excess fluid. And our blood plasma proteins, when fluid is low, it'll pull fluid into the bloodstream from our tissues. So if I had somebody that was dehydrated, so look at how my skin is pretty supple, right? When I pull it up, it's going to go back because I've got fluid in there. It's got a little bit of moisture. I'm probably a little dehydrated, but I don't know. It still goes back normal. If I were dehydrated, I'd pull up my skin and it would stay tented. I'd be dehydrated. You can sometimes see that in elderly people, like that are in nursing homes and haven't been drinking a lot of fluids, if they've been dehydrated, or somebody that's been vomiting, if they're dehydrated, you'll see this like tenting. You put it up and it's like this tent that stays there, and you're like, wow. Okay, that is called poor skin turgor. Skin turgor, Turgor, is how supple your skin is. Um, but theoretically, then the body is pulling blood in from those interstitial tissues, trying to keep the blood vessels circulating or filled, is what it tries to do. Cell membrane and capillary permeability will regulate that too. So, a disruption of fluid balance might be fluid loss, dehydration. So, a total decrease in water volume. There's going to be poor fluid distribution. Water isn't going to get to where it needs to go. You may have too people that have like edema, swelling, where if you somebody that has like ankle edema, you see that in people with congestive heart failure. They'll measure how much it is. So if you have it, you can go home and measure it. If you ever have like edema, the ankles will be swollen. You can press into it, and somebody with true like ankle edema you'd leave a fingerprint in there. It leaves like a thing. It looks like a memory foam. You know, if you go to memory foam and you press on it and it just stays like that, the ankle edema will look like memory foam. Um, and they measure it as to how long it stays imprinted in there, like 2+ edema or 3+ edema. It's how long it stays dented in, is how severe it is. But edema could be too much movement of the water. Swelling can be associated with that, and the water is just moving into too much into the interstitial area. The nervous system, the brain and spinal cord are well protected by muscle and bone, but if you have um, damage to like the vertebrae that causes spinal trauma, but it can also be done by disease. There's also like, let me just kind of show you the linings of the skull up there on the top. You've got the scalp and then you've got the skull, but underneath there is something called the dura mater. Okay, and there's two layers of it. The dura mater, those two layers together, there it stands for, it's Latin for tough mother. Okay, so it's a pretty tough lining. Um, and then there's the arachnoid matter. Who knows what an arachnoid is? It's a spider, right? Spiders has to do with spiders. It looks like a spider web. It's like little like fibers and stuff. That's the arachnoid matter. And then you have at the very, very bottom the pia matter. That's the soft mother. That's the lining on the brain. I'm just going to point this out now, but when we talk about traumatic brain injury, where the level of the bleed is classified by which lining it is above or below. So you could have a subdural bleed, it's below the dura mater. You could have a epidural bleed. You could have an intracerebral which would be in the brain itself. So those linings, I'm just pointing it out now so that you can kind of think about it later. But you can also have, loss of that protective fluid, cerebral spinal fluid that's in there, and you could have problems with that as far as infection, meningitis, something like that might affect that. So, nervous system dysfunction could be trauma, motor vehicle crash, falls, accident, somewhere where you actually damage your nervous system. The level of damage of the spinal cord, everything below it will quit functioning or won't function as well if the nerve impulses can't get through. So, you could have just the lower, they could become a paraplegic, or you could have a quadriplegic if it was a high neck fracture. You can have medical dysfunction of the nervous system, as in strokes. Strokes can be brain bleeds, or they can be just a blockage of an artery, killing the cells beyond it. Infection, meningitis, encephalitis. There can be diseases, and blood sugar can also affect your nerves a little bit. The digestive system allows food and water and other nutrients in the body. So you've got esophagus, stomach, intestines. This would be something as we get into some of the abdominal type emergencies. We'll talk more about that. Um, digestive system may impact hydration levels and nutrient transfer depending on what they're eating and drinking. Their GI tract can be slow. There can be chronic bleeding in ulcers, which would lead to hemorrhage, rectal bleeding, vomiting blood. That might be into a hypovolemic shock. GI system, you'd be thinking, okay, this might be something hypovolemic, whether it's bleeding or fluids. So, digestive dysfunction, vomiting and diarrhea, commonly, can be caused by being sick and just vomiting a lot, and then suddenly you don't have enough fluid in your system. You become dehydrated, your blood pressure drops, you're in shock, need to replace. What is the main problem? It's a hypovolemic shock, so what needs to be fixed? Volume. Give them fluid, right? They don't really need red blood cells. They need fluid because they've lost that fluid in there. But it is a volume problem. So we're going to fix it with that.